Can I start? Thank you. Thank you, Mr. Chairman, ladies and gentlemen. It is my pleasure to be here. I would like to thank Professor Gamal Serur for inviting me to participate and also to participate as chairman in this session, but also as a speaker in this meeting once more in Cairo. I have no conflicts of interest for this particular talk. Now, before we discuss about ovarian stimulation, it is important, I think, to distinguish from ovulation induction, because there are two different conditions. Ovulation, or two different processes anyway. Ovulation induction means, or at least is applied to anovulatory women, and the aim is monofollicular development and monoovulation, while ovarian stimulation aims at multiple follicular development for in vitro fertilization. And the optimal starting dose in ovulation induction is different than in ovarian stimulation. For example, here in ovulation induction depends on the cause. In WHO group 1, which means hypogonadotropic, hypogonadic women, it is FSH plus LH, because LH is obligatory here, and the usual dose is 150 units, the starting dose, while in WHO group 2, which is mainly women with polycystic ovary syndrome, it is the chronic low dose of FSH, 50 to 75 units as a starting dose in the step-up protocol. Now, in ovarian stimulation, there seems to be a difference between the so-called fresh cycle embryo transfer or fresh cycle converted to freeze-all because of the high risk for the ovarian hyperstimulation syndrome, and the so-called elective freezing cycle that starts from the beginning with the aim to freeze all embryos. Important also is the degree of expected ovarian response, hyper, normal, or poor responders. So in my talk today, I will discuss separately about the fresh cycle embryo transfer and the elective freezing. As I said, the cycles that aim at freeze-all from the beginning of the cycle. And in terms of the first cycle embryo transfer, we have demonstrated many years ago that there is a positive correlation between the number of the follicles that are selected and the mid-follicular FSH levels during treatment with FSH, which means that the higher the levels of FSH, the greater the number of the follicles that are selected. And this is also reflected in the serum estradiol concentrations, which increase significantly with the FSH levels and is in fact increasing as long as FSH is maintained high. Now, induction of multiple follicular development, however, means multiple oocytes. And the question is, what would be the relationship between the number of the oocytes and the dose of FSH? Well, according to this large registry from USA that included more than 650,000 cycles, that data were analyzed by the Society for Assisted Reproductive Technology, SART. It was shown that the number of oocytes that are retrieved increases up to a certain dose of FSH, but then as the total dose of FSH increases, there is a significant decrease in the number of those oocytes that are retrieved. The number of oocytes, of course, is important in clinical practice, and this has been shown in this large registry, again from HFEA in the UK, in more than 400,000 cycles, where you can see this data analyzed by Sankara and colleagues in London, that the live birth rate increases in proportion to the increase in the number of the eggs that are retrieved, but this is up to a certain number of 15 oocytes, because after that there is a plateau and then there is a significant decrease in the live birth rate. And similar data have been shown also in this study from China with a smaller number of cycles, almost 2,500 cycles, as you can see, and the highest live birth rate was achieved with a number of oocytes that were collected, retrieved between 6 and 15. So that might be an optimal number of oocytes because after the number of 15, and particularly after the number of 18, there is significant increase in the incidence of the variant hyperstimulation syndrome, as it has been shown in this study from the Swedish National Quality Registry of Assisted Reproduction, data that were analyzed by the group of Christina Berg in Göteborg. Similar to that is this study from Belgium by Papanikolaou and colleagues, a prospective cohort study that showed that in women with ovarian hyperstimulation syndrome, the number of oocytes that were retrieved were significantly higher than the number that were retrieved in in women without ovarian hyperstimulation syndrome. And in fact, you can see that the number is almost double. So there seems to be an optimal number of oocytes in IVF, and there is an upper limit that seems to be the number of 15 oocytes, and there is also a lower limit that is the number of 6 to 8 oocytes. This is derived from the information that I provided to you, but also from mild ovarian stimulation protocols by the group of Bart Fauser, where the exogenous administration of FSH at a low dose limits the number of oocytes to less than 8. So 8 and above up to 15 seems to be rather optimal number. So in clinical practice, we always aim at an optimal outcome, which means the highest possible live birth rate without ovarian hyperstimulation syndrome. And this can be, in fact, achieved if we have an optimal number of oocytes, which can be obtained with an optimal dose of FSH. But the question is, how can we estimate this optimal dose of FSH? Well, this is a difficult task. There have been different nomograms in the literature. However, one of them, for example, is nomogram by Lamarca and Sunkara, where they used the age, the AFC, antral follicle count, and the basal FSH level. And then by drawing lines, they were able to estimate the average dose of FSH that would be considered the best for this particular case. Let's say in this case, they found it was 150 units. They tried to validate this protocol later on in a study that they published 3 years later. And what they did is that they calculated, that was a randomized study, so they calculated the dose, the starting dose based on their own nomogram, and also they compared it with a control dose that was based only on the age of the patients. And what they found is that, excuse me, that the percentage of patients with an optimal ovarian response was significantly higher in those who received the dose according to the nomogram than those in the controls. And also there was a lower response in those who the dose was calculated based on their own nomogram, which means that the nomogram may be helpful. Nevertheless, a subsequent study, this is a retrospective analysis of study of data in Korea. This is only 117 first cycles. They calculated a dose that they called proposed based on the Lamarca nomogram, and they compared it with a dose that was calculated empirically. And what they found is that in two groups, if the dose, for instance, the two doses were the same or similar, they called the group concordant, otherwise they called it discordant. And what they found is that the optimal ovarian response, which was a number of oocytes between 8 and 14, was similar in the two groups. And also the hyporesponse and the hyperresponse, suggesting that the nomogram by Lamarca, in fact, does not provide any advantage over the calculation of the dose empirically. Now, the question is, what is the impact of the FSH dose on the live birth rate? We saw that the impact is on the oocytes, that there is a decrease in the number. What about the live birth rate? Here are data again from this SART registry from USA, and you can see that as the daily dose increases, there is significant overall decrease in the live birth rate, and this is regardless of the number of the oocytes that were retrieved. And regarding the total dose of FSH, again, as the total dose of FSH increases, there is significant decrease overall in, again, the live birth rate, again, regardless of the number of the oocytes that were retrieved. It is interesting in this study that there was a range of dosages, as you can see, between 1,000, 1,000, 2,000, that provided the highest live birth rate, which probably can be considered this dose an optimal dose. The question is whether, in fact, the optimal dose of FSH can be individualized by using various ovarian reserve tests, for example. The answer, according to the Optimist study from Netherlands, is no. This is in hyper-responders. What they did is that they used 150 units dose as standard dose, and then also they compared it with 100 units dose, and they found that there was no difference in the cumulative ongoing pregnancy leading to live birth rate, which means that, in fact, by reducing the dose, the result is not affected in terms of pregnancy or live birth rate, but they found that there was a significant decrease in the ovarian hyperstimulation syndrome with a lower dose, so that there was the mild and moderate ovarian hyperstimulation syndrome significantly lower. And this has been also discussed, or a similar discussion has been provided in this article here by Brockmans. Based on the ovarian reserve tests, in fact, he presented data that he obtained from this Cochrane database systematic review, in which he was co-author. So it was shown here that with the calculation of the ovarian reserve test, there was a significant reduction in the moderate to severe ovarian hyperstimulation syndrome. So it is clear from what we have discussed so far here that there is an optimum, or at least an optimal number of oocytes, probably between 8 and 15. And the optimal dose of FSH appears to be no more than 2,000 units in total, which corresponds to about 100 to 200 units per day, or on average 150 units per day. Now, what about the elective freezing? Excuse me. And I mean cycles that start from the beginning with the aim to freeze all. Well, there seems to be a difference between the so-called fresh embryo transfer cycles and frozen cycles, according to this registry from Sweden that I mentioned before. And in the fresh cycles, this is related to the pattern of live birth rate in relation to the number of retrieved oocytes. In the fresh cycle, there is significant increase in the live birth rate up to number 11. We mentioned before up to number 15 based on the registry from HFEA. So here is about number 11, but after that there is a plateau and then there is a significant decrease. While in the frozen cycles, there is a continuous rise in the live birth rate with the increase in the number of those sites up to a number of 25. There is also another difference between the fresh and the frozen cycles in terms of the live birth rate based on the dose of FSH that was used. And in fact, in the fresh cycles, if the dose was above 2,500, there was a significant increase in the probability of live birth, while this was not shown in the frozen cycles, suggesting that it may be the endometrium that is affected by the high doses of FSH. And in this study, it was interesting that they used sibling embryos that were obtained from the same oocyte retrieval process, and they were transferred into the same uterus. Thank you very much. Thank you. I will. So it is possibly the endometrium that is affected with the high dose of FSH. And this has been also shown in this study here, which again are data from the SART study, analysis of data that were obtained later on, 2014-2015, and they showed that with the increase in the FSH dose in the fresh cycle, there was a decrease in the live birth rate, which was also shown in the frozen cycles, but this was significant only in the fresh cycles. So the high dose of FSH has an impact, negative impact on the live birth rate only in the fresh, not in the frozen cycles, suggesting again that this may be the endometrium that is affected. Nevertheless, if we look at this data that again were obtained a bit later from the SART registry, it was shown that the total dose of FSH can have an impact on the live birth rate in a donor-recipient model and fresh embryo transfer. And in fact, for every 500 units increase in the total dose, there was a 3% decrease in the live birth rate and the clinical pregnancy rate, suggesting that it is not the endometrium, but possibly it's the quality of the site that is disturbed. So there are conflicting data in the literature regarding that. And this is supported further by this study in which PGTA was applied in almost 1,000 frozen embryo transfer cycles. And it was shown that when euploid embryos were transferred, the live birth rate was similar regardless of the use of FSH, the dose of FSH. If the dose increased, this did not affect the live birth rate. And also the age did not affect the live birth rate. And the same was shown in relation to the duration of treatment with FSH. So the live birth rate remains the same if euploid embryos are transferred. And therefore, this means probably that it is an impact on the quality of the site, mainly related to an increased aneuploidy. However, this has not been confirmed by any data so far. These data here are from the Valentia group and show that there are no chromosomal abnormalities between stimulated and unstimulated cycles. So there is no difference if you give FSH or not given FSH, the results are more or less the same. So in fact, they also used 46 cycles, or at least 46 donor women that were studied in both the unstimulated and the stimulated cycle, and they used the same also sperm donor, and they found no significant difference in the chromosomal abnormality. So aneuploidy may not be, in fact, an issue here, and this is also supported by this data from Brazil that showed that the total dose of FSH is not an independent predictor of embryo aneuploidy. So that needs further investigation regarding the impact on the euploidy on the embryos of the high dose of FSH. Nevertheless, despite this debate, recent study here from China has shown that the percentage of the small for gestational age infants increases significantly when the dose of FSH is above 2,500 units. So this is the odds ratio here, either crude or adjusted, and this is statistically significant, of course, suggesting that there may be an impact of the high dose of FSH on the oocyte, epigenetic effects or other effects that cannot be detected with the usual methods. So to conclude, ladies and gentlemen, it seems that there is no consensus regarding an optimal dose of FSH for ovarian stimulation. In fresh cycles, however, the number of eggs retrieved decreases with the total dose of FSH. An optimal number of eggs between 8 and 15 seems to be the appropriate, or at least what we could name optimal, because higher numbers significantly increase the risk of ovarian hyperstimulation syndrome. The live birth rate decreases with increasing daily total dose of FSH, and individualization of the FSH dose does not improve the IVF outcome, but may reduce the risk of the ovarian hyperstimulation syndrome in hyper-responders, for example, women with polycystic ovary syndrome. An optimal FSH dose seems not to exceed 2,000 units in total. In elective freezing cycles, however, the live birth rate increases with increasing number of oocytes, even up to number of 25 oocytes. And unlike fresh cycles, the total dose of FSH does not affect the probability of live birth rate. And the live birth rate from transfer of euploid embryos is not affected by the total dose of FSH. High FSH doses are not associated with embryo aneuploidy. Any detrimental impact of higher FSH doses on oocytes may be due to epigenetic alterations or undetectable changes in oocyte quality and competency. And higher FSH doses increase the risk of small for gestational age singletons after fresh embryo transfer. Of course, more studies are needed. And before I finish, dear colleagues, it's just to show you information regarding European Board and College of Obstetrics and Gynecology, where we organize exams. These are fellowship exams. They have part 1 and part 2. The next part 1 exam will be in May 13th, 2023. Applications are already open. The part 2 exam will be 6 months later. We also are organizing exams in collaboration with ESTRE. These are subspecialty exams. Again, there are part 1 and part 2. There are also fellowship exams, European Fellows of Reproductive Medicine. And for those who are interested, can visit the EPCOG website, also the ESTRE website for more information. Thank you very much for your attention.
Thank you, Professor Messinis. One comment on the marker normogram. Is it, from your opinion, optimal for individualize the dose?
My opinion. Yes. Well, I have not used that in clinical practice. Certainly, we use the ovarian reserve test. For example, if you ask me what I do if I have a patient potentially a hyper-responder, like for instance ovarian polycystic ovary syndrome, and I'm going to do IVF, I start with a low dose, which low dose is based on the syndrome, because the syndrome is at risk for the ovarian hyperstimulation. And if you consider the optimist study, you could start with 150 units, because 150 units will provide the same results with a lower dose, but this will be the live birth rate. But the higher dose, the standard dose, will increase the ovarian hyperstimulation syndrome. So in order to avoid that, what I do is I use lower dose. Unless you go for freeze-all, and in that case, of course, you give GnRH antagonists, as usually in PCOS, and you trigger the final oocyte maturation by using the GnRH agonist, and then you freeze all. In that case, you avoid the ovarian hyperstimulation syndrome. So the ovarian reserve tests, because the Lamarck nomogram is based on ovarian reserve tests, is based on AFC and AMH, and age, of course, and FSH, but in the ovarian reserve tests are useful, but they cannot be, generalized, I would say. It's only for specific cases, maybe.
Thank you. Any comments?
We published a study in 2017 with the Japanese of 14,000 cycles of natural cycle single embryo transfer, and we interpreted from that what was the intrinsic fertility of the human oocyte at any given age. A huge statistical number, so it was very consistent. And at any particular age, the baby rate per egg was 4 to 5 times higher without any stimulation at all than with controlled ovarian hyperstimulation. And then we compared that also to later, just Clomid-only IVF cycles. And of course, we got less eggs, but the baby rate per egg was dramatically higher at any given age you wanted to look at the curve. And so it would seem like your end result is negatively impacted by overstimulation per egg, at least.
Yeah, well, you mean overstimulation?
Yeah, by higher dose FSH and overstimulation,
yes.
COH.
Yeah. If you give higher dose of FSH, you will obtain more oocytes, but not certainly much higher than you would expect. I mean, you can increase the number up to a certain level, and then the number will decrease if you increase the dose. So that may have an impact not on the total number of oocytes, because that may be adequate, the total number for subsequent embryo transfer as well. But probably if you go for fresh embryo transfer, you may have not very good results. And in fact, the live birth rate is also decreased with a very high dose of FSH.
Yep.
So I think we do not need, very high dose of FSH. We need moderate dose. And in the past, I remember that we used up to 450 units. Now this level is never reached. We do not go above 200 or 250. So very high dose is not needed, in fact, unless you go for freeze-all. In that case, yes, you will obtain, let's say, 30 oocytes. You freeze all of them, and then you go for, multiple embryo transfers in different cycles in the future. And in that case, you can calculate the cumulative live birth rate, which may be okay, may be good. So you will have one shot and you will do many embryo transfers.
I agree. In the U.S., many centers are sort of impacted by the drug company reps, and they routinely use 450 to 600 IU of FSH per day. And the results are terrible, but they think by giving more gonadotropin, they can get a higher success rate.
Yes, okay.
Thank you. It's a pleasure for me to introduce the next speaker, Professor Hussain.